Radia. What? Hello? Are you ready? Okay. 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 Assalamu alaikum. Good evening, dear colleagues and friends. Welcome to one of the meeting MEOM Retina Hub that's done physically, and today is sponsored by Novartis. We'd like to thank Novartis for sponsoring this meeting. And we'll start with the first presentation by dear Dr. Hassan Hassan. It will be about Torozumab in DME, and he is an ophthalmology consultant, retina team leader in Dubai Hospital. Dr. Hassan, thank you.
Assalamu alaikum. Thank you, Dr. And I would like our respected panelists today to organize the first presentation for me will be about the Thank you for attending with us today. Today I will speak about Torozumab in diabetic macular edema. Thank for Novartis for sponsoring this presentation. As you know, that just review got the approval from June 2022 for the DUB using diabetic macular edema. As we discussed, diabetic macular edema, the presence of the intraretinal fluid, subretinal fluid, it will be affect the vision, DME or more, according to the pathology of the diabetic macular edema. Disruption of the inner retinal barrier, it will cause leakage of this intraretinal fluid or subretinal fluid, and affect the retinal sensitivity, which mostly will affect the vision of the patients. So if we go for to see that this intraretinal fluid or subretinal fluid, according to the post hoc analysis for the protocol T, you can find that the patient in the baseline, the patient mostly they have, if they have intraretinal fluid or subretinal fluid, mostly they will have worse visual acuity. And again, if we go for the protocol I, again, even the patient who has consistent or persistent macular edema, it will be even continue for a long time, even until the third year. Around 40% of these patients, they have persistent macular edema. This means to affect the result of the patients. Even if we go back to the protocol T or the post-hoc analysis, that these patients will receive the aflibercept, even that monthly injection with even risk for treatment by the laser, still around 1/3 of the patient or 1/4 of these patients, still they have persistent macular edema. And through protocol I, that we found that even the patient who has the relation between the proportional relation between the amount of macular edema and the number of the vision will begin reverse proportional relations. That with the patient who has more macular edema, he will have less gaining in the visual acuity. Then, for the rule of the way we will improve the visual or anatomical outcome for diabetic macular edema, especially with fewer number of injections from the beginning of the treatment. So understanding the pharmacological part of the medication, this is compared between valuable medication. You can see the golimumab is the smallest molecular part here, and it's around 25 kilodalton. This is mean that we have higher penetration feature, and again, it will have even more number of molecular in the dosage compared with by the other medication. This means to give maybe kind of durability for the medication. For the kite and kestrel, which compare between the PUVU and the aflibercept, this is the multi-site study. The difference between kite and kestrel, the kite there is just compared between 6 milligram PUVU and aflibercept 2 milligram. And the idea was here in the kite in the week 70, they give the extender to go for more than 12 weeks to go for 16 weeks. Kestrel will go compare between two dosage for the PUVU, 3 milligram and 6 milligram and aflibercept. The primary objective to be the non-inferiority between the PUVU and the aflibercept from the beginning, from the baseline visual acuity until the week 52. And secondary endpoint was the proportion of the patient who kept on the 12 weeks interval of injections, and second, the proportion of the patient who from the PUVU compared between the two medication, intraretinal fluid, subretinal fluid, OCT findings from anatomical outcome, and the percentage of the patient who kept on the Q12 intervals of injections. The inclusion and exclusion criteria, the most important thing that all the patient was naive patients, no patient with the BDR in this study, and most of the balance between the demographic and even retinal finding between the two studies. And you can see even here in the intraretinal fluid and subretinal fluid around the same. From the loading dose to maintenance, as you know that the PUVU given every 6 weeks in diabetic macular edema, then they extend it for 2 weeks, 8 weeks or 12 weeks, depending on the primary evaluation time. It will be here the first disease activity. It was decided for the medication to be in the 32 weeks, and when we compare between two the medications already. The aflibercept they used in the regular or label medication, it was using every 4 weeks for 5 loading dose, then every 8 weeks, depending on the approval for the medication. And on this sort of evaluation, you know that the patients in the aflibercept arm already received one more injection than the PUVU. Again here, after the evaluation of 32 weeks, it will be decided for the patient will go for the Q12 or Q8 treatment. This activity, it was masked investigators. And stability, again, it will be here for the kite, as we explained for the kite, well, in the third 70 weeks, they will decide it can extend it for more for 16 weeks. And when we compare the two medication, we can find that the difference between the two medication was give the efficacy of the PUVU to be the same as or non-inferior to the aflibercept, with less number of injection in the first year. Again, around in kestrel and kite, around half the patient in the first year was in the Q12 maintenance treatment, and this is evaluation for the first year around it's considered from 36 weeks until 52 weeks. Around 90% of the patient was in the Q12. This is the secondary endpoint to look after the intraretinal fluid or subretinal fluid compared between the two medications. You can find that the superiority of the PUVU to be better than the aflibercept and the dryness, subretinal or intraretinal fluid. In spite of this endpoint wasn't studied statically for this purpose. But according to the numbers, it was separated. It's another one. This is even after they look at after the 52 weeks at the end of the first year. And here again, they look at the other marker of the anatomical outcome. It was the OCT. Again, here is the OCT on the preview arm was better than the aflibercept. Again, secondary endpoint wasn't statically studied. About the safety, when we speak about the pembrolizumab, this is the most important thing for us about the safety of the pembrolizumab, because depending on the outcome rate, that there was cases of around 3% of cases they have intraocular inflammation, or even they have occlusive retinal vasculitis. So if you go for the overall safety, it was around comparable between the medication and the cardiac cholesterol. And if we go for the most important intraocular inflammation, it was just in the kestrel. There was one patient with 6 mg has retinal vasculitis with occlusive retinal occlusive issue. And on the other side, the kite, both the preview and the aflibercept, they have occlusive retinal accident, but wasn't accompanied by intraocular inflammation. So if we, from this, that we compare that there's maybe kind of difference between even the intraocular inflammation when we compare it by the AMD patients. It could be related for the disease. It could be related for the patient here in the diabetic macular. The patient mostly they have a metformin, and this metformin, or sometimes they say that it will be affect the inflammatory reaction in these patients will be lower than the others. For any reason, in the cardiac cholesterol was the intraocular inflammation was around the same time, but in the cholesterol the incidence was 1%. And just I want to share, maybe after the approval, we tried this indication. We tried in the CMVM before, but for us, maybe in diabetes, we recruit patients. This one patient, maybe this case was a patient has history of anti-VEGF received as previous responder, then shifted for steroid. Then the patient received bilateral Iluvien in May 2022. But the patient present has good response. You can see here, we follow up the patient after 4 months, subretinal fluid. There is drill here, there is retinal fluid. But the patient hasn't any improvement in the OCT or in the vision. The vision was 0.3 and 0.5 in the left eye. There is subretinal fluid in all, in spite of the steroid, generally this retinal fluid will be absorbed directly. So we decided to top up by the BUV for this patient. And you can see there's huge difference in the left eye OCT. In spite of this is very chronic, you can see the exudates. The patient has resolved subretinal fluid, and the vision improved for 0.7. And for us, the right eye even improved one line. So resolving of the subretinal fluid, improving the OCT and the vision. So we decided to continue on the loading dose for the BUV. Just I want to share another case from us that about the efficacy of the BUV and the subretinal fluid. This case of orboidal PCV. The patient has came to us for the treatment, and we advised him to go for the BUV. So from the second injection of BUV, we can see the patient received, the vision will become 1, and anatomical was very good response. And you can see here, even this is maybe the last OCT for the patient was stable, and the patient was in the Q8. In the beginning, we went to the Q12, but he has recurrence. So we changed it for the Q8 until that maybe after time we will extend them more for Q12. So again, if we go for the kite, you can see even in the second year, you can see still that surely there is a huge difference between number of injections between the BUV and the aflibercept, because aflibercept was using the fixed treatment every 8 weeks. And again, for the patient who was around 45% of the patients, and both these studies was on the Q12 interval of injections. And about the safety, even the safety for the patient, extended for the 2 years is the same as the first year. So as we speak, the rule of the view and diabetic macular edema, it's comparable to the aflibercept, and less number of injection with extended between the interval of the injection until 3 months or even 4 months, 16 weeks. And here is the loading courses every 6 weeks, and the patient can after that go for the Q8 or Q12 depending on the primary assessment. It will be in the 32 weeks. Thank you very much.
Thank you very much, Hassan, for this very nice presentation. Is there any question from any of our panel or any speaker here or any attendees? Anyone want to comment, please?
Dr. Hassan, the only limitation seems to be in both Kester and Kite studies, the populations that have been taken are North American and South American. The only Asians taken are Japanese.
Yeah, they say that there's more Hispanic races in the American one. But this is the demographic. They mentioned that the Hispanic race was more in the Kite and Kester. But it was.
I would actually emphasize the absence of the Asians, the true Asians, the mainland Asians, not being included in this study, which are going to be our treatment population.
I think we are waiting now the real world data from this medication. We will not depend on, even if you go for the kit and Kestrel, for us this is not the real life. The real life is compare the medication and the real life that to extend the aflibercept even if you want it. This is just for the approval of the medication. So you can find that some difference because the recruitment was strict. They need patients without any history of anti-VEGF. They need patients without PDR. So recruitment sometimes strict the study, I think.
Any other questions?
Dr. Hassan, I just wanted to ask you, for a treatment naive patient, what is the protocol you follow for you?
In our hospital? Yeah, we are a governmental hospital. So when you... Yes. If you ask me, now we live in the time where we have this kind of medication. Before I remember that when you reach the Avastin, it was a huge achievement for us when during my practice in my primary hospital in Syria. So the Avastin was a dream for us. Now with this number of the injection which we have it, if you ask me, I prefer to give the chance for the medication. Even in that, if you see that Q6 is very important. When you deal with this is very important. And I think the battle between the medication will not be stopping. You will see another extended for the loading dose. So if you ask me, if I have one patient in our hospital, generally, if you have to enter a new medication, you need an approval. So depending if I was free in the clinic, surely I will request the new medication because we have the faricimab and we have the BioView, but this is, we said in our hospital is non-stop. This doesn't mean you can't prescribe, you need an approval for that. Approval doesn't mean you need one. Depending on the situation, if the patient is CMDM, we will not wait, but if the patient is diabetic, sometimes we apply. You can see that we use it. I think maybe the time was strict for me, the time until bring the cases. So we use the BioView. Until now, we don't have any cases. We try to choose the cases, but for us, I prefer that to see this medication in the real life. This is the study. We see there is difference. If you ask me, I saw clear evidence that BioView is good in the patient with polypoidal polymorph. So in the chronic macular edema, as in this patient, there is rule. Maybe the others, maybe we can see that shifting between anti-VEGF sometimes we not expected because this molecular is very small. This is theory. We don't know. In the real life, we will know that this is clear.
So, Dr. Hassan, thank you very much for this nice presentation. For the real life, we have a guest 1 or 2 months ago from India, and he did also a study on real life patients. and he didn't have any reaction or these side effects, the vasculitis or intercurrent inflammation. But he used this medication as PRN. He didn't follow this free loading dose, and also he found that in the cases of polypoidal, this medication did very well. And surprisingly, he didn't have any even he has a case of more than 100 cases.
I will share one case with you.
Yeah.
I wanted to put it in the lecture just to give at least to give the attendees that something that we have a patient with polypoidal, and we explain for colleagues. We try for him everything. So in the end, we think that we give him even charisma. But the patient singular, when we speak with her, she's already bypassed here and here about BVU. We wanted as a team to give her BVU because we saw this case. But the patient sadly, in the last treatment by the other medication, she developed intraocular inflammation. So here we can't use the BVU. So we said she ran from the intraocular inflammation, then she got it from another medication. Yeah. So for me now, if you ask me if the patient came for me as we have polypoidal choroidopathy, I will advise him for the directly BVU. If you ask me about the patient who received steroid injection, I will advise him directly for BVU. I will not choose another medication because this medication is already tested. About naive patients, I think that the patient who didn't like to go for the monthly loading dose, we can try it for him. As we said, the intraocular inflammation according to Guy and Kistrin is not as in the AMD cases. So maybe related for the diabetic, as we said, diabetic mellitus pathology. So I think that now just approval of 1 year, this medication, any medication generally when you practice it will mean you need time until you have. This is when you try it with the aflibercept before dexamethasone, then you look at.
Thank you, Dr. Hassan, for nice comments and guidance. I think what Dr. Sandeep meant, are you feeling comfortable to start with BVU in naive DME? I mean, to start treating DME. Of course, in polypoidal, as you mentioned, you feel comfortable to start right away with the medication. But for diabetic macular edema cases, do you feel comfortable starting with this? Especially because some for me, for example, sometimes I give aflibercept not every 4 weeks, the loading dose, maybe every 5 weeks, 6 weeks, and it works fine. So I'm not sure, I don't have the experience to say in DME, but I think this is what Dr. Sandeep alluded to.
Yeah. Again, we go back. We have new medication. And if you ask me if the patient came with me with subretinal fluid, extensive macular edema, and he's naive, and I would take him for the anti-VEGF, mostly I would choose the. For me, I feel that the time to try this medication, to see this medication is better than aflibercept or no, aflibercept is better. So according for us, still, even this, if you go for this study, it's for the approval, not the real life. Even the aflibercept, there's treat and extend, and they reach the Q12, Q12, Q14. But if you ask me, before we was shaking from using the BVU in the AMD. But when we tried in one patient, this patient, he reached 1. Generally, you will not find the polypoidal to see this patient. For us, it was magic. So it could be that the practice of this medication give the chance to use it.
Any other comment or questions?
So basically, I have been using BVU since its inception when it was started in ADL. I think I started using the molecule since 2021, and till now, approximately, I would have done around 100 till now, and haven't had even a single reaction. And actually, regarding what sir was telling, one-eyed patient, till now I have treated 3 one-eyed patients. After gaining experience over a year, I found the molecule was good. So one two of these patients, one-eyed, advanced AMD, used to recur on IDEA, and they had got almost around 18 to 20 injections till now. Those patients are with me since 5 years. Shifted on one single dose of MEOM. I mean, I gave them loading dose of MEOM. Immediately after that, first time ever the patient could have, I straight away shifted the patient to 3 months, 4 months, and since the last year, patient is treatment free. So, and especially talking about diabetic macular edema now, I mostly prefer MEOM because what I've seen is that all these newer generation molecules, like so we talk about this loading dose. Loading dose was talked at a time when Avastin was there, and even after the first dose of injection, it was not enough to clear the fluid. But once we start using BME, you see that even 600 microns, they just vanish in a month's time. With such injections, I personally feel that many times we don't need, and many times just one injection finishes the whole fluid, and then I straight away start on PRM. So that has reduced the use of the injection per se in terms of the volume, and it gives very fast results. So especially in DME, it works very, very well. PCV, yes, absolutely no doubts about, but even in DME, what I've seen is I don't need to complete a loading dose. One injection, finished, fluid is dry, and then straight away go on to the PRM regime. It works very well.
I want to ask, just for me, maybe for us, a governmental hospital, we don't have any bias for any medication because we know that we need the patient to be extended. Just go on. I don't know. The private, this is the real because it came to my ear that sometimes because in the private, the patient and the loading doses will be every 6 weeks, different than 1 month. So the income for the doctor it will be different. So this is did you hear?
You are attacking on the.
No. Just
other way around.
It's actually the other way around. Our income has gone down because of UV.
Actually, if you see the effectivity of the drug, we all know that the drug is extremely effective. Okay? And the safety in diabetic macular edema has been well established in comparison to AMD. Drying effect is excellent, longer lasting effect, less number of injections. This is what we need. Unmet needs. If you have persistent fluid, then you have to give more number of injections. So BME is quite effective in those terms. And in real life and clinical trial, if you compare, it's very different. You know, many a times patient actually skip loading doses also. You will not be able to give loading doses. So BME is an ideal drug in that situation because you still have this good drying effect which lasts very long. So you're not worried even if he skips a dose, the drying effect will still remain. So I think more and more experience and then more and more.
Yeah, the feedback will be
So more experience with the drug will make you more confident to inject in diabetics, even treatment naive patients. I think it should be good.
This is.
So actually, I have also given almost 50 injections of BU, and actually what I realized in the private practice, as you're asking, that if you give a first injection, patients give some improvement, they get a ray of hope, they stick to you. If you are giving injection, no, it's not working, we'll give one more injection. It is very difficult for a patient to understand that you need 3 or 4 injections consecutively. Giving a BU, immediately after 2 weeks, there is a dramatic improvement, and it increases the confidence of the patient. And I really use loading doses. After 1 injection, we started and fortunately, there is no so far any intraocular inflammation.
I use a different strategy. I start my patients with DME with guided crystal criteria. So I tell them that we'll give you 5 loading doses 6 weeks apart. And in 1 year, I've had 1 patient who was supposed to receive 4 injections. That's it. So once I see a flat macula, I discontinue that loading dose pattern. So, I mean, on an average, 3 injections are good enough for a double diffuse DME. Use assisted DMEs.
And I think one more point which Dr. Mohan had raised was that BME came at a time when it was peak COVID. We were having a lot of patients coming just without anything with vasculitis. I've seen most of patients post-vaccine coming with just vasculitis without anything. So it could be a scenario, it could be a confounding factor which probably no one took into consideration at that time. And if actually we see the studies now, the post-marketing data which is coming on BOU, since then, like probably post-2021, the incidence of vasculitis has significantly gone down and probably very, very rare. Most of the incidences happened at that time, which I believe this was a very important confounding factor which no one took into consideration. That could be because of in general.
Even Dr. here, I will not mention, like I mentioned here, one of the patients, he has the blood, he has COVID and died already there because of the COVID. So even that, this is, they mentioned in the study already, as you mentioned. Thank you for
I have been using BOU, and what I found out from my experience that I'm very comfortable with using diabetic macular that is established. I have no presumption of having any apprehensiveness in using the drug in DME. Yeah. In neovascular AMD, because of the age factor, sometimes it's very difficult to determine which patient is going to get the inflammation. However, the rate of inflammation has much reduced now, and it's much less in diabetes. And it's around, now it is less than 3%. But whatever inflammation did occur, those are controlled. But vision threatening inflammation, which is arteriolar occlusions, that is around 1%. So people are confident now, but in aging patient is very difficult. There is something called anti-drug antibody. So the level of that in the system is very difficult to determine. Okay, so however, the lab investigations or the study will show that the patients who had a higher ADA level, those are the patients with an inflammatory response, okay, which are type 4 hypersensitive. So it is, but in diabetes, yes, we are confident in using, and I'm very comfortable in using. But now comes the point of loading dose. You know, it's very difficult to tell the patients because the drug works so well. So what I do in diabetes, you can call it a PRN, but I take it, I customize this as an individual patient study. So once I keep the BOU, I call the patient at 6 weeks because 6 weeks I must give the loading. I check, and it's good. But I want my loading dose to be on the, I usually don't give more than 2. But however, I go like this. I give injections, I check at 6 weeks, and 6 weeks dry. I call at 2 months, I give the second, okay? And then I again call it second month, and it's dry. I extend it 3 months. And then I give the 3 months dose, then I give the other. And most of the time, I don't need more. And this is a good part of BOD in DME. You know, it works wonderful. In AMD, you have to justify yourself based on the patient. But in little younger AMD patients in the range who are around 50, 55, I'm comfortable. Because in those patients, less chances of getting an inflammatory response, so aggressive. And it works wonderful. Today, my patient came after the 4th dose, his fibrovascular PD has flattened down. So I'm going to repeat it again after 3 months. And he's eager to go there because after so many years, he saw him flatten down before he had that reversal. So I think you should individualize a patient. But remember, as the age goes up, I personally feel the chance of getting an inflammatory response.
Even the gender, you go more with the gender, the female more want to have the vasculitis.
Yeah, so you have to customize your own patients, but always study from your patients and apply. Okay, but follow the general.
Thank you very much for all this comment. Just I will have a small comment about, let's say, to conclude about the OBU. I was having a good experience in treating the patients in the early beginning on AMD. And I have done many patients of AMD in the beginning, and even I have done some of them, they are naive patients. Okay? And unfortunately, I didn't find any inflammatory process in all of the patients. And actually, most of them, whenever they get the first injection, they come to you to tell you, please give me this medication only. I have it. And because it's really, it was, even for me as a doctor, this is the first time when I faced that you are giving an injection from 1 week. 1 week. The patient improves from counting feeder to 0.3, 0.4, and he is an AMD. This is something magic for the patient. And they are very satisfied, and there is no problem. If you are, the most important, you have to look for only examining the patient, and you can interfere in the right time if there is any inflammation. This is in AMD. I didn't have a chance actually to do in diabetic macular edema till now, but I think, yeah, as doctor, I have one patient, he was over 80 with AMD, and I gave him 3 injections, okay, and it was, unbelievable about,
This is what I'm saying, that you won't be able to predict. Okay, now I'll tell you what is the rosy picture I face. I have patients with inflammation, to tell you the truth. I have patients who lost vision. Yes, so that is what I'm saying, but I still use it. Because that is how I customize my patients. I don't believe on who comes and tells me what. I believe on my patient. I always go back and see what works good. And that's how I make my own table formula.
And Dr. Nadim, if you go and see why there is no inflammatory process in the patient of diabetic macular edema, it's available, and maybe one of the factors you mentioned, the age, but it could be something else. It came to my mind like this, because it may be the loading dose. The other one they are giving every 4 weeks, while here they are giving every 6 weeks. Is one of the reasons it could be. Yes, the duration. Also, most of the time
it comes out.
Yeah, the real life it will change, but at the same time we cannot prevent our patient from getting improvement, because there is 1% that they will get this complication. So it is at the end, it's a type of how which patient you are going to select. So already you have taken a lot of time in discussing this topic. So thank you very much, Dr. Hassan. Thank you for all. So now we can move to the second part of our meeting, and I will handle this mic now to Dr. Awallah. He will moderate the second part, and we will have panelists with our Dr. Sandeep and Dr. Abdulaziz and Dr. Awallah. Sandeep, Mandeep, you will be the first.
Thank you, Dr. Omari, for your invitation. I think we start first with Dr. Mandeep.
Thank you, Dr. Amri and MEOM, for this opportunity. Good that we have a lot of time for different kinds of discussions. So I brought up this topic basically. It's a simple, straightforward case presentation. I just want to know views at different points of management of this particular patient. How would my colleagues manage this particular case and stepwise approach? So persistent fluid after vitrectomy is nothing unusual. We see it day in and day out in our practice. This particular patient was a 61-year-old Emirati lady who came with bilateral vision loss, type 2 DM. She has had cataract surgery done in both eyes, PRP done in both eyes. You are moving or I am moving it? Okay. So the eye of interest is the right eye, which was 0.1. PCL, she had a partial PVD, ERM, typical vitreoskytic picture with traction retinal detachment having 2-3 different foci. This is how she presented to us. She quickly worsened. This was 1 day pre-operative, and that's what I did for her. Routine PVD induction, and there were multi-layer split, which was nice as in split. So did a vitrectomy, removed the membranes. If you see around the superior and inferior arcades, that's where the real traction RD is. Macula is more or less actually attached. There was fluid under the retina around these focal detachments. So I was able to dissect the membranes without creating any retinal break. Went ahead and removed the epiretinal membrane, along with that the main trunk on the optic disc.
eventually did ILM peeling, a small ILM peeling around the macular area. Did an FGE, endolaser, very, very routine stuff, nothing, no alarms actually. So, I will skip this part, I think. So, poll one, okay. I need your opinions. How many of us would like to actually do a drainage retinotomy or extended ILM peel in this particular patient?
ILM peeling, yes.
Extended ILM peeling, of course, but do you want to extend it to the arcades wherever that disturbed area was? Or
None of them.
none of them?
Moving the island?
Yeah, but not extended, right?
Extended.
Up to the arcade you will not do?
No, I didn't do, but it's open house, you know. You might like to do things a little differently.
And here presentation.
So by extended ILM peeling, he means beyond the arcades. Right?
Yeah, beyond the arcades.
Beyond the arcades.
No, and we'll not do drainage repair with the pump.
Yeah, obviously.
Yes.
So, poll two, what would you like to use as a component in this particular patient?
Air.
Air maximum acceptance.
Okay, so I think all of us are on the same page. Air. This is how this patient fared at the end of 1 week. She had a significant amount of subretinal fluid, which actually pooled up onto the macular area. That's how she was 1 month later. The fluid hardly moved. It neither increased nor decreased. This is how she was 3 months later. If I can show you the topography of the macula, this is how it looked. Practically did not move at all. So what would be the next course of management? There is no retinal break, nothing. I've screened the patient, retina is seen.
Behind detachment or a traction?
This was a traction retina. There was no break.
This is subretinal fluid.
This is subretinal fluid.
Shifting from up. So for me, coming from up, I will observe with the yellow.
I had exactly the same case.
I will observe 1 month.
From this picture,
No, I don't. That's all I have.
I have exactly the same picture, and I reoperated, and I did the posterior retinotomy. It is very thick, entrapped fluid.
Exactly.
It's going nowhere, and it's going to detach the attached macula.
So that's my next question for Dr. Abdullah.
So I mean, if you go there and you try to find membranes, you won't be able to find any because you did peeling, good peeling, you did ILM peeling to start with. So this sometimes you get this entrapped fluid under and it's going nowhere, very thick, it's not improving. So I tried, I put dual blue and I tried to see anything, there is nothing. So by the end, I even injected PFCL in order to stabilize the posterior retina, trying to squeeze fluid to any unseen breaks. You won't find any. So by the end, I resorted to the old good method. It's not very good. This posterior retinotomy, temporal, superior, small, and remove PFCL and fluid air exchange with the range of this.
What's the kind of fluid you found?
It's very thick fluid, it's very thick, proteinaceous, and it's not going to absorb. And the problem with time, this is encroaching upon the macula, and this one is just threatening the macula. It's going to decline.
What will be your timing of surgery? How long will you wait? What would you choose out of this?
This is almost.
It's now 3 months. Now 3 months.
Involving the fovea, right?
Yeah.
So you have to operate immediately.
I will not do the surgery.
Yeah, want us to discuss.
Yeah, absolutely. Open
For me,
I
will speak about this case. Yeah, I will speak about this case. Dr. Mandeep, when he removed the macula was attached, the fovea was attached, and it didn't create any break. So what happened? make air fluid. This is my explanation. When you make air fluid exchange, gravity came and all the fluid that are came to the posterior pool. So for me, this is need the RB to be good. I will go to make the healthy blood pressure, diabetes. If sometimes maybe I'll give him Diamox if the pressure is good to the eye. I try my best from here and to here. But I will not do the surgery for him unless there is a within break. Because it will be absorbed maybe within months. Then I can give injection, but I will do the surgery. I will not do the surgery.
The problem immediately after surgery, if you do OCT, the macula is flat. There is no evidence of fluid. There is no evidence of fluid whatsoever. Then after 2 months, the patient didn't follow up, and he just came. Can we see the picture?
I don't have the picture.
The OCT picture here. Yes, it's bisecting the fovea here. It's almost very close to the. It's almost. You have to go for surgery.
The vision is around 0.1 at this point.
This fluid cannot be like this. The fluid will be chronic changes in the fluid. So I think vision in the long run. We need to operate, and I think gas would be a good
yes.
idea for this.
You make
It is an outpatient gas exchange, which is not a surgery.
See, I think the first time they operated, this could be a combined. There could be a micro break.
See, when you looked into those slit line biomicroscopy, you feel retina is absolutely attached. Absolutely attached. There's nothing, no membrane, no break. But when doing OCT, you see this.
I have case like this, and the patient totally absorbed by within 1 month. So I have another friend. He shared cases. The same. He go and put oil.
The oil is bad choice.
He put because diabetes was repeating the surgery. So put oil. For us, I feel that you can't try any conservative before doing the surgery. At least give the time for the patient. Because
if you have this fluid post-scleral buckling, you have such kind of a picture post-scleral buckling where you do a non-drainage, fluid is not connecting to any retinal break. Maybe a month or two, you can still wait as if the fluid is going down. But in this situation, you definitely.
If it was this, according to my knowledge, I don't know. It was this.
So if you decide to go for surgery, what timing? Would you do it at 3 months? Like Dr. Abdullah will go in, Dr. Thakur will go in, Dr. Hassan will wait.
I will wait. For me, the threshold would be 6 weeks. 6 weeks to 2 months maximum, and depending on the patient's comfort.
For me, after
that's important.
After 6 months, actually, we can observe the CT, and we can check the volume of the fluid. If there is a decrement in the fluid volume, we can observe. But if there is the fluid is not going, volume is not going less, so after 4 to 6 months we can.
So Dr. Nazim, what do you think? Dr. Nazim? So you have
patient will not be there, RC will not be there.
There won't be vision improvement even if the fluid absorbed after 6 months.
There won't be any vision improvement. There will be chronic changes.
I will wait for at least 2 to 3 months and keep on doing the OCTs to see if the fluid is increasing. 1. And 2, if I at all have to go inside, I must be sure that all the retinal all around is good. I will stain again. Okay? 1. The 2, I might use a 41 gauge and use an active suction so I don't have to laser extensively to make a retinal. Okay? So 41 gauge is good. You do active suction and suck the fluid out. So active suction will anyway be required because this fluid is very thick and protein high. And that is why it doesn't.
Even if you do the fluid exchange, not typical fluid exchange, and then do fluid
exchange. Yeah, first we'll do a fluid
and then remove 41.
41 gauge in the beginning of it. Okay. You don't do retinal, you use a puncture therapy.
Yeah.
Actually, my patient was already 3 months after.
So if you see, certain articles which cumulatively present this kind of data, that this kind of PSF reduces it, recovers spontaneously in 100% of almost like 100% of the patients in 1 to 2 months. And some patients, some of the articles say that around 5% of the patients, this kind of fluid can still persist till 12 months. So I wanted to wait for some more time. So this is a post-op at 6 months. This is at 9 months. Fluid is still not going anywhere, but you see the superior part of it, it has now started regressing. And now it goes 12 months. At 12 months, you see a little bit, maybe fovea is getting attached, her vision is improved to 0.2, but still, and at this point of time, patient is really getting apprehensive, but when I tell her to go for the surgery, she's a very old lady, she doesn't want surgery. At the same time, she's unhappy with me that vision is not improving. So 12 months now, that's how 6, 9, and 12 months OCT look like. Minimal changes, but still frozen fluid, absolutely. So now what do you do?
After 1 year?
After 1 year.
Don't do anything.
All right. So at this point of time, she was unhappy, but she was not agreeing for any surgical intervention. So I tried something different, which I read in a couple of articles. I thought, let's try the most non-lethal way and go ahead and do a laser photocoagulation and RP stimulation. So there are certain reports in the literature on laser stimulation working in this kind of cases of not PSFs. PSF have been shown strong correlation with choroidal hyperpermeability, and that has been proven along with ICG and FFA findings as well. There are certain treatments recommended, like use of eplerenone, just on the lines of CSR, which have shown that they do work in such cases as well, if you want to go conservative. So what I did is actually at 1 year post-op, I did a grid photocoagulation for her. Don't ask me why. It was just an RP stimulation. I did not have micropulse laser at that point of time. So this is how 3 months after the, 4 weeks after the laser, the patient started resolving. This is 6 weeks post-laser. It's immediate effect. 8 weeks, she was absolutely flat and she was 0.7. And 29 months, that is almost 2.5 years later, she's maintaining that foveal integrity with 0.7 vision. So a fluke which worked, I can call it a fluke. So if you look into the PSF and causes, it's actually the chronic nature of the fluid that we have been discussing, and amount of pre-operative macular elevation before the surgery has got a strong correlation with amount of PSF you can have post-operatively and the duration. Presumed causes of PSF are extensive intraocular laser, intraoperative laser, confluence of laser along the arcades, presence of microbreaks, which are ruled out here, choroidal hyperpermeability, associated myopia, persistent traction, we have discussed that, combined mechanism, Dr. Thakur was saying the same, and overall dysfunction of the RPE. And that's where the hypothesis of RPE stimulation actually comes into picture. So the effect of PSF, of course, we know it can create photoreceptor damage and permanent vision loss as well. To conclude, pachychoroid is one condition that should be ruled out, and laser photocoagulation, multipulse, BDT, eplerenone, all have been shown to work. Before you move into a surgical intervention, you can try these. To conclude, in such a case, there is no role of long-term tamponade, no role of extended ILM peeling, there is no role of drainage retinotomy initially. And in case of persistent subretinal fluid, now this is important, we'll come back to it later, does not impact the final physiological outcome at 1 year. Now, when you talk about persistent submacular fluid, there's a difference defined between reg RD and traction RD. When we talk about thick fluid, it is supposed to have those proteinaceous pro-RPE factors, which does not allow that RPE disintegration to happen. So despite of, if you leave this fluid over a period of 1 year, you do get good results in terms of visual acuity. However, this fluid, if it is from reg RDs, they are not so forgiving. So had it been a reg retinal detachment, I would have gone in and intervened probably at 6 weeks, 2 months or something like that. But because this was purely a traction RD, I just waited for quite some time. Thank you.
Thank you, Dr. Mandeep, for a nice case. So my understanding, you did the laser, the PRP on the attached retina.
I just did a classical grid photocoagulation, which we used to do for diffuse DME initially.
Away from
no, on the detached portion.
On the detached.
On the detached portion, that's tough fluid.
So what's the end point? Did you get like any joke point?
I could get a faint.
Because there's fluid elevation.
Fluid was transparent, doctor. So I could get not exactly what the kind of reaction that we used to do in classical grade photocoagulation, but you could see the faint laser marks. But that was objective actually. It was not to go in and charge that part of the retina, just to stimulate.
To stimulate is the same mechanism as we used to do in grid
Yes.
for macular edema.
So if you have multiples, you could actually do a micropulse laser also.
Thank you, Dr. Manib. I think for the sake of time, we would move to the next case. Dr. Hassan.
Again, just will share one case and we give you advice. Yeah, go for it. This man came for our emergency that he has high myopia. The patient has 37 millimeter axial length, and he has bullous RD. You can see here the bullous RD, and the patient has horse rotator at 12 o'clock. So I decided for him, the patient is the easy thing. Go for lunatic retinopathy at the beginning, run away from this case. So I injected gas. You can see the proof of the vision, but the patient has after the dissolving of the fluid, patient within 2 days, the residual fluid, but the fluid didn't improve. We discharge the patient, we do the laser for the break up and discharge him. And we thought that this could be hypotonic, because the patient had hypotonic, high myopia. So maybe there's the residual of the fluid. We examine again, there's no tears at all. The problem is that the inferior RD came back and the patient had hypotonic, and the superior the brake is attached. The sector where the brake is attached. So now we can, where is the brake, the ear brake, we indent the patient, then we decide for the patient to go for vitrectomy. And during the vitrectomy, the brake was here. This is the reverse, upside down. This is the machine. You can see the fluid here, the clear fluid come from the optic nerve, peripapillary area, parapapillary area. And the staphyloma, the tear is there. So, what you advise me? What should suppose for the patient? Now the brake is here. What you advise me to do for the patient? How can I repair it?
Where is it? It is between the...
Yeah, the brake here, on the staphyloma, on the optic nerve, peripapillary area, in the staphyloma, not in the retina, there is no RB. The retina, when they come out from the vessels, come from the optic nerve between two major vessels. So I worked very nice. So here, you can see it here. You'll see it now in the video. So what you advise me what to do for the patient? Because I have another case, experienced this. So
the hole is on the atrophic area?
Yeah, in the peripapillary area.
Yeah, peripapillary.
This is staphyloma. The patient has 37 millimeters.
No. Is it
the slit-like here between two major vessels. Slit-like. The fluid came from here. This is the back flush. Fluid coming from here. What's supposed to the patient? The peripapillary area.
Hassan, this photo is not clear. We can't.
The tear is here.
Yeah.
The optic nerve, yeah?
Where is the optic nerve?
Here, I will. Let's go for this again. No, let's go back to the video.
And this is the Kina court. You are trying to use PVD.
Can you just go for the second slide? Now go the back. The video more. No, back. Let's go on. The surgery. How do you know he's do the vitrectomy.
Okay.
Remove the vitreous.
Yeah.
Here the tear was here, this area. Now I discovered that where is the tear? Bullous RD. From where? But I know that the verified exam here, the sector where the retina was attached. So when I enter, I said there is surely one tear. But when I examine this, you can see now the clear fluid come from this area. So I know that the problem is here now. And there is traction in this area, which make this keep the fluid worse. So just you will see the video go on up because I shared this video with your retina. So I already did it. So you can see the fluid came the subretinal fluid in the adherence of the vitreous to that area. So here I want to see where in this area, this the phenome here in this area. You can see it's here. Between two pages, slit-like. Then I make the. You can see it's here.
It's almost like coloboma cases. Coloboma cases on the edge.
Yeah, here after I remove the vitreous.
This is ILM or this is?
You will see it now. This is a clear tear because this is I did a patient for him with the fluid, then I did BFCL, then now he just I clean the vitreous. Then I mark the area because I can't see it to be clear. When I go at the back, when I try it, you can't see it. So I mark it. You can put the VFCL, you can see the staphylomas, everything is here. The tear is here, in the staphylomas area. So I have another case. Why I share this? Because I have another case. I finish it. The patient has back with retinal detachment. So I repeat it for the ILM. Here you can see I remove then I use the ILM. I suspected this could be even optic disc width. So I put the batch here. Then I remove but you know that putting the batch under without BFCL is nothing. You need the BFCL to be.
Can you stop one?
Now, you need the video. Just to make it, can you just pass the video? Just go to the hub or more. And put the.
This video or not?
This one, yeah, more. So what I did here, I use even the BFCL to fix the retina posterior wall. Then I put the ILM.
Schlieren signs. It's clear now. The Schlieren.
What do you use as temporary gas?
Gas.
Yeah.
Yes. I put the ILM after I used the BFCL. Then I took the ILM batch. Here, what you will do? You put the ILM. Cover the tear, or where you will put it, or what you will do, retinotomy. Somebody's use retinal graft. Somebody's you will use just as I use here the ILM. Somebody's they use even blue. So here I decide to put because I know there is no RBE here in this area. So my plan was to put something, tuck it inside the staphyloma to prevent any fluid to go back, and that will depend on the RBE on the other side on all the retina to keep the retina attached. At least avoid any entrance from this. Because I have another case, the same high myopia. The patient after I didn't do it for lab, then the patient has repeat retinal detachment.
So yeah, Hassan, do you think if you do only ILM peeling and do fluid air exchange and use the gas, this
for me, I have another case. It's failed. Even I can share it.
Maybe yeah. So sometimes we find this one in high myopic focus. And even we do iron peeling and extend it to the edge of the staphyloma and do fluid air exchange and use gas and.
It could be, but for me, I want to close the defect.
Yeah.
Because here is that the staphyloma here is not normal. It will be generally the posterior wall of the retina will not be regular. It will be irregular. It will be as in two walls connected together. If you see that here the staphyloma and here is the tear. So for me, I feel that this area is different than this area. So I want to put something here to tuck it. You can see this is the tear. So I took one batch. Then I use the BFCL at least to more manipulate ILM. I put one patch here too, because I suspected it could be here optic disc pit. So I put a small patch. Then I make here, saving the phobia. I make then I remove the patch and I tuck it inside the tube.
Yeah, so as same as if you deal with macular hole, but this is in the optic nerve.
General macular hole, I don't tuck it. Generally, I will cover it on the surface because they said even the prognosis. You can see it. I tuck it here because in the end you see the OCT. So I finish here. I make retinol to make air fluid exchange because I want to remove the EFCL and to avoid any fluid to come to the patch. You can see the last. This is maybe the last slide. Then I do the laser for the retroctomy area. Then I put gas for the patients.
So when you injected this,
here the retina, just let me. And here the phobia, and you can see here is the patch which I did. This is here is the tear, and here is the ILM tuck which will be. And the patient improved even for 0.4.
Very nice. But my question: when you injected the BFCL, the fluid is still there, and
the periphery.
Still.
The periphery.
That's why you
because even the previous patient, I used the subretinal brain blue to see if there is any leakage. So for me, it was from the beginning. I searched the periphery, nothing there. The fluid was stuck in the periphery. I know that the problem was in the optic.
Nice job.
So what's your choice for this patient? You will choose the ILM autologous graft, choose retinal autologous graft, amniotic membrane, posterior capsule graft, biological glue, 360 or 270 parabellary barrage laser. What's your choices? I was here in these cases. It could be here because there is a report about using the laser around this here to prevent.
Is it a bit? So if the diagnosis is optic disc field, you can use the laser as a barrage. But even in the optic disc field, and there is some like CSR disease, even if you do vitrectomy and BVD, use BVD and do the ILM peeling, and the fluid will be absorbed.
Because I said,
but this one is different. Yeah, for me, maybe I would think to do that, but I will not do this autologous grafts or. I will deal with ILM.
Yeah, because even she used the biological glue. She put the biological glue, even the optic disc.
You can use trying to tell you that there is a nice paper. What you did is wonderful because you cannot laser that. So tucking in is a good idea because it's a slit hole. If you tuck in, then the edges will come together.
Try to fill the gap.
Exactly. One. Two, that biology glue, recently there was a presentation last year in American Society. So it was wonderful of not doing a vitrectomy and drainage and put that tissue glue or the biology glue over there, and then you will see that to disintegrate over time, and you don't need to laser it. So biology glue may be an option there, okay? But easiest is what you did.
Because why I said for some, maybe as Dr. Abdulaziz mentioned the important note that he said that you can do cleaning the ILM without tucking. It will do the work. For me, the previous one didn't do the work. It was the same. I cleaned everything, and I said I was encouraged enough to put the gas for the patient. Khalas, finished. The patient came back with inferior retinal detachment. Then we go inside. We put we inject through the stair. We inject the membrane blue and we reach the periphery, nothing there. So we know that the problem here. So I said, in the second, then I will not make the mistake. So
I think this is a variant of retinal detachment associated with coloboma, because with coloboma we can see these slit holes on the edge of the coloboma. It's a localized coloboma. With the optic nerve pit, we have maculopathy, so we do not get retinal detachment. Mostly. So these are exactly what we used to see, but this is a nice case because it's a localized coloboma. You add this slit, and you have to tuck. You cannot just put a flap of ILM. I think you have to tuck it. You have to tuck it inside. You can tuck also Sometimes it's very difficult to create an ILM in very high myopic patients. In this patient, amniotic membrane graft
As we did for
would be
any chronic macular.
because it's really hard to
Have you used the normal?
No, here 37. So I use the extended.
Which ILM force have you used?
Here you can see that I don't use the ILM here. I use the indicribbing myopic force. This is 38, 30, or 40.
This is a nice.
That's even though we open our
it's not that
20.
easy.
Yeah.
Thank you, Dr. Hassan, for a very nice case, stimulated discussion. And we'll move to the next surgical case presentation. Dr. Mohit.
Good evening, everyone.
مش يستفيدون
Thanks the organizing committee. Thanks Dr. Muhammad for giving me this opportunity, and special thanks to Mandeep. He almost covered all the topics. So I'm also going to discuss about a similar case. So my case is also a persistent submacular fluid after diabetic diabetic vitrectomy today. So actually. I had a 65-year-old gentleman who had diabetes for last 15 years with coexisting hypertension but no nephropathy. And I operated the left eye 6 months back for combined detachment. There was a hole in the nasal periphery. So surgery went well. We removed all the membranes in the first sitting. Retina was well attached. But even after 6 months, there were some fluid pockets at the macula. So we can see the extent of the fluid. Where's the point?
Pointer.
Yeah, so we can observe here the extent of the fluid. So fluid was localized, well confined, and periphery of the retina is well attached, and it's been 6 months. If we compare between the level of fluids, the 3 months fluid after 3 months and the 6 months is almost same. The volume is almost same. It is not resolving. So what should we do? Observation or any intervention? Since there was no resolution of the subretinal fluid, so I thought for the intervention. So what may be the options? So I had no clues about doing the laser or this type of fluid, and I had no experience. So that was out of question at that time. So what options we had? Actually, the primary surgery I have done island peeling. It was quite extended from arcade to arcade. Matter of fact, I extended the island peeling beyond the lower inferior arcade. So there is nothing that we can remove except there is a small area where we can see that the artery and the vein are very close, and maybe there is some contracture here. And matter of fact, there was some island peeling. Island is also there. So I thought better I go inside. I'll remove this membrane and try to figure out what else we can do. So the thought that I had that this is a chronic, tractional retinal detachment. There is an intraretinal shortening. So if I drain the fluid, even draining the fluid will not help to settle the retina. So what if I make a multiple retinotomies that helps in relaxation of the retina itself? So once the SRF will start resolving, these retinotomies extend and become like an elliptical, and it takes the contour and helps in the retinal reattachment. Yeah. So we did the siliconal removal. We observed the periphery. There was no traction. We stained. You can see that there is such a good island peeling was done, even just going below the arcades. So there was island of the island that I removed. And I was able to remove the small membrane over the arcade here as well. There was not much tissue. I tried to grab if there any membrane at the multiple areas, but there was nothing. There was slight fibrous tissue over the blood vessels. I tried to remove and I was successful to release this fibrous tissue also. But I can observe the retina is very taut, stiff. So I just really, I know that it is not causing so obvious contraction. I accented the island peeling beyond that also, but I was not able to get a flap because it comes in little bits. So whatever is possible, I extend in the temporal periphery as well as the inferior periphery.
So what is the theory for extending the island peeling? Why you would?
In the first surgery.
No. This is the first or the
This is the second surgery.
Yeah.
No. Actually, just because I want to remove all the island over the area which is taut and where the fluid is.
Still there was contracture of the...
Still there is like, the umbrella, it is like a top. So I did the retinotomies in this fashion. This retinotomy is exactly where the epicenter was. One retinotomy I made inside the arcade. Idea is not just to drain the fluid, just to give some space for the retina to get relax and settle down. So there's a total 4 retinotomies I made. Very tiny.
What is the grade?
It is 25 days. 25. So after removing all the SRF, I find difficulty in doing the laser. I'll just show it here. So the laser reaction was not coming great. So I did multiple times, fluid suction. But I still realized that intraoperatively the retina is very stiff. Even with the force suction, it was not coming at so a position, and the laser reaction is also not coming so well. So next day, the first post-op day, there was a fluid. Almost a similar amount it was MEOM. But it started resolving. At 10 days, there is a much reduction in the fluid. And at 4 weeks, the fovea was attached. There was slight fluid in the inferior arcade. But it takes around 10 weeks for almost complete resolution of the fluid. But there was slight fluid under the fovea that resolved further. So,
but this,
yeah, I again put the silicone oil. The reason was after the laser, I was not confident that there was such a good laser reaction, and I may need to supplement laser in the post-op. So, and it was such a taut retina. I had a real confusion to put the gas or the continue with the oil. But I favored in the oil and put the oil here.
I think the fluid absorbed it because of the Maldives. But it didn't need to operate.
Yeah, of course.
And I think as Dr. Nazim said earlier, with a 40 gauge cannula with very active suction, you can get all the fluid, because I don't think the fluid was drained through the retinotomy to start with.
Before you removed it, I could see in the macula a lot of diabetic changes. Okay, did you intend to do a fluorescent angiography first before doing the silicone?
I did not do any angiography.
But how this could be related to the subretinal fluid?
The subretinal fluid, we do not know whether it is whether the diabetic maculopathy itself is also contributing. Yes, okay, one. So that then you might also think Mandip's lead may work on that. One.
Yes, this is a good point.
Okay. And number two, it was not showing traction on your OCT. So there is nothing called it is cooling like this and become like a tabletop. Because many times in chronic case like Monday, it may be possible. You have a lot of scars here, and the center retina, if there is fluid, it doesn't settle because there is a pool.
many times in recurrent arteries when we operate, which I operated a month back, somebody operated 5 times. Okay, when it came to me, the whole macula, the posterior pole is not settled. It is like this. Yes. I had to relax near the scars, then it's settled. Okay, that thing can happen in Mandi's case where there is extensive scars or glazed. But in your case, I would have done an angiography and tried to see that area. And this is very difficult to tell, but here, you know what, a thicker gauge will take out the protein field.
So, yeah.
If you ask me from my, I don't know, I mean, really, I'm sorry to speak with Dr. Abdulaziz here. He's our mentor. He has the experience. If you ask me, I will not open retina to remove subretinal fluid, chronic one. Because all of my trials, always I regret. I regret because I don't reach my level which I wanted. I said I will remove it. Then I inject fluid under the retina. I make all the retina bullous. Then I don't take it. If it was years there, you can't. From my practice.
Hassan, you have to use silicone oil because.
Yeah, other than this, the same.
Because
in this case.
So I said I prefer myself to put here for the patient.
We don't do as Hassan said because we can't wait.
So if I'm going to drain, what I do is to inject a bubble of BFCM over the optic disc. So it pushes the fluid to the periphery and it causes a dome because it's entrapped, it's going nowhere. And at the apex of the dome, I just do the retinotomy. Then you can see the fluid coming all the way up.
So the problem
in this case,
PRP is done.
This is gel for me.
Yeah, in this case, you have put the oil in.
But here the retinotomy didn't.
So now the question is when oil, which I hate, because oil causes a lot of post-injection inflammatory response. That is why many times you see in artists when you do, you can see.
So better to put gas because the silicone stimulates the proliferation.
In your case, since oil is there, you're going to remove it. Now, question is either you fill the island with a bubble of gas and chrome it, so the fluid is pushed down like you do in case of large fluid.
Even sometimes, Doctor, in our practice, we can. Dr. Monet, which he did it. In our practice, sometimes the patient you can't forgive you.
Yeah.
He needs vision. If you repeat for him the recurrent retinal detachment, so you said at least the oil give you the short window, or then you can know that it's a detached retina, or because the detached retina he will not accept it from you. Attached, because when you put the oil, the patient has vision content. Sometimes we do this. We practice.
The most important
we practice this.
The patient was since 6 months he's not having a good vision. Then putting the gas and not good vision is a real challenge. And retinotomy also I was very concerned. I thought I'd need a laser again to the retinotomies. And the metaphite was not settled. And I tried to remove all the fluid, like multiple times I did the removal of the fluid by the active suction. So fluid was removed, but retina was not settling because it was so taut. So
yeah, so sometimes what you do, this 25 gauge when the tip is there, the silicone tip, it becomes difficult sometimes.
It's good.
It is good for us. I take it out.
Yes.
Okay, then
green tip, it was a blunt tip, not the green tip.
See, at the end of the day, the surgical principle is that whatever is good in your hands, okay? But there is some basic principle. Whatever holds good, if you feel oil gives you good and it's your experiment, go ahead. But follow and try to understand. Is the oil causing an inflammatory response, or is it that diabetic changes is causing it? But many times when you don't touch it, it is also good. And that is what over the years that we have learned, that we don't touch, many times we just keep it. And diabetic fluids are less harmful than a reg RD. Okay? Because reg RD fluids moves around, comes out of that, goes to the vitreous, whatever subretinal your biochemical properties are there, there's a loss. But in diabetic, it's a strand. So those biochemical component is still there. So the amount of photoreceptor damage of the RP will be less than in case of reg RP.
3 months and 6 months, there was no change in the fluid.
Yeah, that is different because your oil is there. So you have the excuse to go out, in and take out the oil.
Yes, yeah. After some time, you have to go in. I mean, you are not going.
There was fluid before also. You operating also, there was.
Yes, of course.
But again, you have a sick RPE in diabetics anyway.
So, but
stimulating is.
The Mandip case that the vision is improved to 2028, and even he waited for 1 year.
But again, Dr. Nazim said that you have to. What if we do fluorescein? You have ischemic maculopathy. You have the
No, but I don't think this case is related to diabetes.
Yes, it is. It was not so.
It's a very thick. Very
also not there. So how the angiography I'll deal. I have not even any idea like what angiography will make a difference in the management. What the features we have to look for in the angiography. So actually, if we go for the I'll come later on. So if we go for the literature, we realize that the study shows that this persistence of retinal fluid takes almost some study shows that is an average. On an average, it takes around 4 months to 8 months for the complete resolution of the persistence of retinal fluid. So not and even they find that around at the end of 1 year, around 10% of the patient, the fluid doesn't resolve. In another study, it was around 1/3 patient, the fluid is not resolved even after 1 year. So then they have to go for the intervention. So it is not like a clear idea like where we should go and what we should, if we go inside the eye, what should be done? Like ILM is already been removed. So what else? Like he says the laser can be done. Any other idea that we can go ahead for that?
Yeah,
only observation and no intervention.
Yeah, what you did is that if you do this retinectomy and do fluid exchange, it will be enough. If you didn't do the ILM peeling, because the theory of doing ILM peeling is to remove the scaffold for the current PPR. And also, if you inject some medication for diabetic retinopathy, it will be faster. This one. And also, removing the fluid, it will be easy. But ILM peeling is not a treatment. Only to be sure that there is nothing in the interaction of the retina or
So in that sense, like ILM, it is there very strong hypothesis. It is there in the literature as well. That once the ILM is over there, it torts the retina. Like it prevents the relaxation of the retina. Once you remove the ILM, it makes the retina more elastic to settle down. So that was the concept.
It's a controversial. Controversial.
That is controversial.
Controversial. So many discussions in all conferences. To peel or not to peel. We can go till the morning. Debate.
This guy said that I am peeling but answer successful. Now he presented, Hassan presented the 95% results. Okay, if you leave it like that in 6 months. Yes. So what did you say? So each one case, you need to study those cases. What was their case? Like what is Hassan's case? And what is his case? So but the basic principle of what you understood, like how to approach, that one thing is correct, that you must give observation of that. Okay? And then
what
I also like to ask you, like I've done in few cases, there are relaxing retinotomies. So do you think that is relaxing retinotomy, like making a hole that allows the retina to relax, is having any significant importance?
Without fluid exchange?
No, like you made a retinotomy with the fluid exchange, but rather than making a single retinotomy, multiple retinotomies, one exactly at the epicenter, that gives some space for retina to relax and settle down and taking the
I don't think intractional retinal detachment, we do central relaxing retinotomy.
I think
mostly relaxing retinotomies are peripheral and rhegmatogenous. And it's not for a whole.
Relaxing is not.
Yes, it's not pinpoint. It has a criteria.
It is what you did is mostly like we used to do before, maybe 20 years before. Yes, we used to do fenestration or subtensional fluid for optic field. It didn't work well.
And then, yes.
So you did something like that. You diagonalize the inner retina.
And also, retinal shortening has a criteria, or a retinal shortening. You have to. There is no signs of retinal shortening in this case.
Relax means he was relaxing.
Are you relaxing? So thanks for all the inputs. Thank you.
Thank you.
Thank you very much for this excellent session, as usual. So at the end, we would like to thank all the speakers, panelists, and attendees for this really very nice meeting and gathering. And if you don't mind, we need to take only one photo here, so for a reminder that we can have our dinner. Conclusion? Okay.
So, to conclude, the view is a good medicine for DME, and laser is good for persistent fluid.
This is the conclusion.
You're not trying to view for persistence of macular fluid here.
Yeah, but if it's micropulse, yeah, it will be a good idea. It's micropulse. Yeah, absolutely. Okay, can we take it?
Yeah, can please here, one side and the other side. One to the other side.
Yes.
Yalla, please, please can you come?
I think this محمد ما بدك تصور يعني؟
بدي اشوف وين الموقع عشان
اكيد موجود
جنبك بالذات
ما بحبش الاضواء
تقدر كده حيجي الكل ممكن كان يقول ذا اذر سايد ارجع ورا شوي يا معلم
انا تمام الله فاين
Thank you very much.
Thank you very much.
So the break or the dinner in the
ماشي
دكتور عايزين نهايه تاني معلش
بدي اعيدها تعال لسه بدي اعيدها
لا تعال ما نستفيد.
لا بدي اعيد
انا قلت ان الصوره
لك يا
كانت الظهر عندي بس الصوره ما ظهرتش Can we want to repeat it just for
تعال لحظة. يلا تعال دي سكان بالجوال أقصى جيم. يلا أنا محمد. دكتور
لازم السكرين يبان يعني.
طفي البروجيكتور والله من الصبح على الهندسه انت اليوم
ما انت معلش
من هون من هون لا ده حاجه
هذا هيك جمع على بعض.
حلت المشكله.
مرتين ثلاثة وتأكد إنها طلعت.
خلصنا بسرعه اليوم خلصنا بالديكور راح السلايد
تسلم ايدك يا حسن
لازمها في الاكاديمي دي على طول.
لا عيدها انا
فكرني بالجلوكوما كنا بنعملها زمان على الايدج بالجلوكوما سليتس كده وانت مش شايف احيانا كنت بحقن
هي حتى
عملت
كيف لو انا ماسك مع البدايه عرفت النفس يقول دايركت ولا لا يمكن يقول دايركت خلاص حضرتك ممكن تبعتها
حضرتك ايفون
لا لازم ايفون بقى
هو ايفون انا بحضر لك على الايه دروب على طول
لا مش عارف
طيب اديني رقم موظف حضرتك
05 611 9 226
هاتوا
سجلوا عندك عشان انا معاك على طول في الفيديو.
تمام اوكي حضرتك يا دكتور.
طيب اديني بس نزلت وانا هسجل الرقم. تسلم حبيبي شكرا.
Was nice. يلا يلا.